Hi, welcome to JointWorks. My name is Jennifer Perkins. I'm the Program Coordinator for Orthopedic Services at Memorial Medical Center. We appreciate you choosing Memorial for your upcoming hip or knee replacement and look forward to taking care of you. JointWorks has been around for a long time. We started in October of 2003 and have been constantly working to improve our program so that you have the best outcomes possible. The purpose of this class is to help alleviate your concerns and just better help prepare yourself for your upcoming surgery. After you review the video, please feel free to call one of the educators if you have additional questions. While you're here, there's a whole team that will be helping you to succeed. Obviously, you're the most important because you're the one that's going to be making all those right decisions. You have to get out of bed after surgery and do your exercise. You'll hear that probably 10 times at least. That's the most important thing. Also, if you have a friend or family member who would like to participate in your care, they are more than welcome. They can offer a little bit of moral support and a little of encouragement along the way. Your surgeon and your physicians will be a very big part. The nursing team is always there to help you, and you'll have various therapists, physical therapists, occupational therapists. You will have assistance with discharge planning, so don't worry about any arrangements that need to be made ahead of time. We will help you with that while you're here in the hospital. There's a variety of different people who will come in contact with you. They've done a recent study that has shown that in any given hospital stay, about 70 healthcare professionals will come and interact with you on any given experience. So there's a lot of people who want to help you succeed. I'd like to encourage you to take some time to look through your binders. 2 or 3 times is probably better, but it's got a lot of great information about your surgery. And again, if you have any questions about what you read in your binder, feel free to call us directly. There are business cards stapled on the inside cover with those phone numbers. The information in the binder will help you understand what's going to happen while you're here in the hospital. If you're having a hip replacement, they'll talk about some possible hip precautions, talk about some equipment that might be helpful for you to get around after surgery, and then probably most important is the exercise program. One very important feature that you'll find in your binder is a list of pre-operative exercises that you should be doing right now all the way up until time for surgery. So take a look for these in your binder. There's several exercises and give these a shot. Try them twice a day, every day until it's time for surgery. What you'll find is that the recovery afterwards is going to be much easier if you start your therapy ahead of time. Along with your exercise program beforehand, it's also very important that you see your medical doctor for a history and physical prior to this procedure. That needs to be done within 30 days of the surgery, so if you have not made your appointment already, please do so right away. If you see a specialist for medical care, such as a cardiologist, also make an appointment to see that doctor as well so they can make sure that you are safe to proceed with the hip or knee replacement. You'll also need to make arrangements to do your preoperative testing ahead of time, blood work, EKG, x-rays, that type of thing. If you need assistance, please call your physician's office and they'll be able to help you. Now, another thing you'll notice in your book is a medication chart. And this is a great table for you to put down all the medications that you currently take. Some people have a list of medications already printed out for them. Some people don't. It's a great idea to have a list with you at all times. So you put down the name and dosage of each medication that you take on a routine basis. Some of those medications your doctor is going to ask you to stop taking about a week or so before surgery. Typically, these are the medications that have a tendency to thin your blood. Blood thinners, aspirin, ibuprofen. There are some multivitamins and herbal supplements also that thin your blood. It's a good idea to stop those about a week beforehand. However, if you have not received clear instruction from your physician about which medications need to be stopped, please don't hesitate to call the office, grab your list, run through that list of medications to see if you have those special instructions. Now, you'll probably hear about 3 times not to eat or drink anything after midnight on the morning of surgery, and that's very important. It can be very dangerous if you go into surgery with something in your stomach. So you'll be asked not to eat or drink anything. However, some medications your doctor will want you to take with a very small sip of water. This is a medication like a blood pressure pill, heart pill, that type. So again, your doctor will give you specific instructions, and if you are asked to take medication that morning, please take it with the smallest sip of water possible. Okay? Now the last column, different dose on the morning of surgery, that's primarily for people who take insulin. Because you're not eating or drinking anything, most likely your doctor's going to ask you to take just half of your normal dose of insulin. If you take a pill for diabetes, check with your doctor, but most likely they're going to ask you not to take that in the morning. We will be checking your blood sugar periodically throughout the day. Okay, so I've now asked you to stop taking aspirin and ibuprofen. That may be what you're taking for pain. So check with your doctor, but most likely they're going to let you take Tylenol for pain if you don't have a prescription medicine already. Tylenol or acetaminophen is safe to take prior to the procedure.
Hi, my name is Jackie Davis, and I'm a registered nurse here at Memorial Medical Center. I'm going to talk to you today about some of the blood thinner choices that your surgeon has for you. So I'd like to talk to you about the Coumadin therapy. It's also known as warfarin, and it's a pill that you take by mouth once a day. And there's some blood testing involved if you take the Coumadin therapy as your blood thinner. That blood testing will tell your surgeon how much Coumadin you need to take that evening and also for the next several days until they do the next blood test. That will continue on for about 4 to 6 weeks. Now the dietary precautions that are listed here, these are items high in vitamin K. Vitamin K in your body works to thicken your blood, and so if you have a steady amount coming into your system on a daily basis from that list, then you can continue on, such as margarine. If you use margarine every day, continue on because it's the same steady amount coming into your system daily. If it's something that you do not use daily from this list, then stay away from those items just for the amount of time that you're taking your Coumadin therapy. Go back to your regular diet once your Coumadin therapy has been completed. Our pharmacy has created a pamphlet, looks just like this on the board, and you will have this when you're discharged from the hospital if you go home on the Coumadin therapy. Everything that is on this list right now has been taken right out of that pamphlet, and you will have that before you leave the hospital. The injection form is a medication that you will probably see while you're here in the hospital, but the nurses will come by and they'll give you this injection while you're here. And sometimes people go home with the injection form as their blood thinner therapy. Now, if that's the case, we're going to teach you how to give yourself that injection before you leave the hospital. And also, there's a video that you can watch as many times as you want to make you feel more comfortable in how to do that process. It's a self-injection. 1 to 3 weeks that you would take that medication, usually about 7 to 10 days would be the length. In the hospital setting, you're probably going to see medications like Lovenox, Orixtra, or Fragmin as your blood thinner therapy through the injection form, but when you go home, probably it will be Lovenox. Your doctor and your nurses will teach you about that medication before you leave the hospital. Another couple of medications that you might see or hear about, aspirin therapy on its own. This is a pill that you take by mouth once or twice a day according to what your surgeon has ordered. This usually lasts for about 3 to 4 weeks. And the thing about aspirin is that it is harsh on your stomach. So we want you to get a coated type of aspirin and take that just as your doctor ordered, once or twice a day. Also, you want to take that with a meal because that aspirin is harsh on your stomach. 3 to 4 weeks. And the rivaroxaban or Xarelto, that's a new medication out there, and it's new to the United States since November of 2011. They've been using it in Europe since 2008. So we've been watching the studies. We, the FDA, and the surgeons here in the States have been watching the studies, and they found that this works great as a blood thinner therapy for hip and knee replacements. So if you see this, then we're going to call your pharmacy and make sure that it's available to you. And also we're going to call your insurance company and make sure that that's covered by your insurance company. If it isn't, we'll give you an amount for that medication, and then you and your surgeon will discuss that. If you need to change, they can discuss that with you while you're in the hospital. This medication is about 2 weeks duration that you take this. There's no blood testing, there's no dietary precautions, and it's once a day, one of 2 strengths. It's either 10 milligrams or it's 20 milligrams. So it's pretty user-friendly. Now, there are a couple of types of anesthetics that Dr. Satovia, one of our anesthesiologists at Memorial Medical Center, will be talking to you about, and he'll describe them in detail. There are a couple of things that I want to point out before we go to that video that you're going to hear Dr. Satovia talk about. One of the things is a special monitoring device. It's called capnography, and this has a little clamshell looking device on the end of what looks like oxygen tubing. So while you're in the hospital, for 48 hours after your surgery, you're going to have this oxygen tubing with that little clamshell, and that clamshell is going to measure how often you're breathing and how deeply you're breathing. This is a good thing because if you're breathing too shallow, then that 48 hours after surgery, there's a little machine that's right behind the head of your bed, and it's going to alarm, and that will probably wake you up. But that's a good thing because that means you need to take a deep breath. We worry about people who have shallow breathing after surgery, and because of pain medication and anesthetics, you might have some of that shallow breathing. So this will help to alarm and wake you up to take a deep breath. So if you have sleep apnea, we want you to bring your machine in, your CPAP machine or your BiPAP machine, because we want to use that while you're in the hospital. And the machine itself will give you the right breathing during the night. Now you might see this on during the daytime, just to make sure that you're getting the right amount of respirations and you're taking those nice deep breaths. Now this will only stay on for 48 hours. You can take this off while you're eating. You can also take that off while you're doing your therapy sessions. But again, it's a protective measure for you to help you take those nice deep breaths when you've had your surgery for at least 48 hours. So after surgery, I just want to tell you about a couple of things that you might have. After surgery, you could have a Foley catheter, which would drain urine away from your bladder and collect in a bag. The nurses will empty that periodically, and then we're going to take that out about 24 hours after your surgery. We want to make sure that you're getting up and going to the bathroom on your own before we send you home from the hospital. And your hospital stay is probably going to be about 2 to 3 days. Another thing that I want to tell you about is that during a knee surgery, sometimes they'll put a cuff around the thigh to help decrease blood loss. So if on your surgery leg you notice some bruising or some cramping maybe in a circular area, it's because of that cuff that they possibly used during your surgery. And also, you might have constipation. In fact, I think I'd just better say to you, you are more than likely going to be constipated when you leave the hospital because of all of the pain medication that we will be giving to you. So in the hospital, they're going to talk to you about a stool softener, and you're going to take that twice a day. Continue that at home twice a day for as long as you're taking your prescription pain medication. Also have a laxative on hand. In fact, maybe get that and have it handy at home before you even come into the hospital on the day of surgery. That laxative, take that in the evening by the end of the day if you have not had a bowel movement, and then the next day, hopefully you have a bowel movement. If you don't, take the laxative again that night. Now, if it's been several days after your surgery and you have not had a bowel movement, you need to call your doctor or your home health nurse or call a healthcare provider and let them know, and they can help direct you on what you need to do next. Another thing that you might see while you're here in the hospital, a possibility of a drain near the incisional area. Now this would wick away any fluid collecting at the incisional area, either at your hip or at your knee, and it would wick away that fluid, collect in a little bag, and that will be removed before you leave the hospital. The nurses will remove that for you, and it's just a pressure sensation when they move that. It's not stitched or sutured into place. If you see that, you'll know what that's for now. And I'd like to introduce you now to Dr. Satovia. He's one of our anesthesiologists here at the hospital. He works very closely with our JointWorks team, and he'll tell you about what types of anesthetic you have and also the different options available to you, and those will be discussed on the day of surgery. So here's Dr. Satovia to tell you more about that.
Hi, my name is Scott Satovia. I'm one of the anesthesiologists here at Memorial Health System, and I'm going to talk to you today a little bit about the anesthesia and pain control methods we employ here to help get through your total joint surgery. Here at Memorial Health Systems, we have a team of folks that are going to care for you that mainly do orthopedic cases. That includes your anesthesiologist, your nurse anesthetist, and your surgical nurse and techs in the operating room. We've tried to develop a plan here to get you through surgery as safe and as effective as we possibly can to help you get back on the road to recovery and participate in your therapy as best as possible. Turns out that that's probably the most important part of the whole process, is getting you active again and exercising as much as you can to get your new joint working as best it can. As far as anesthesia goes, we want an anesthetic that's going to be reliable, that's going to let you participate in your therapy, that has a low risk of side effects, and that in the past has consistently made patients very happy when they've compared what we recommend now with what has been done in the past. What we are currently recommending for your total knee or total hip replacement surgery is a regional anesthetic. And that's different than a general anesthetic because a regional anesthetic just affects a certain part of your body rather than putting your whole body to sleep. There are a lot of advantages of having a regional anesthetic over a general anesthetic. Those include less blood clots in your legs, otherwise known as DVTs. You have less blood loss during certain types of surgery. You'll have less wound infections afterwards compared to a general anesthetic. You'll have less nausea. You'll have better pain control in the short term as well as long term. The regional anesthetic I'm specifically talking about for your types of surgery is a spinal anesthetic. In addition, it seems obvious, but since we can do a spinal anesthetic or a regional anesthetic in place of a general anesthetic, we can avoid general anesthesia. And this avoids a couple of key things for you. One is we can avoid the breathing tube, which we have to put in during a general anesthetic, and we can also avoid the ventilator, which folks typically don't like to be on. You'll usually have a sore throat if you do have a general anesthetic because we put the breathing tube in between your vocal cords. It's very common to get sick after general anesthesia, so we can avoid that as well. And the major problem though with the general anesthetic is that it's either on, so you're asleep, or it's off, so you're awake. So when you wake up from surgery with a general anesthetic, you're going to have pain right afterwards rather than the spinal anesthetic, which wears off in a slow fashion. The other problem we found with general anesthesia is that your memory can be affected. For some folks, that's just the day of surgery, but for others, it can last up to a few months after surgery where your thinking just doesn't feel quite right to you. And we're not sure the cause of that, but again, if we can just avoid the general anesthetic to begin with, it's not going to be an issue. When you have your spinal for surgery, we do sedate you, and we sedate you based on how well you're doing. And what that means is if your vital signs and your breathing are good, we'll keep the sedation medicine going. And for the vast majority of patients, that means you won't remember anything about being back in the operating room. There are certain medical conditions that can affect how much sedation we give you, and those typically are sleep apnea. So if you use a CPAP machine at home or a BiPAP machine, that will sometimes limit how much sedation we can give you because obviously you know that you have some breathing problems to begin with, and the sedation affects those even more than your baseline status. So we'll give you as much as we can, but we can never promise that you won't remember something about being in the operating room. The thing though is if you do remember something, it's not like you don't have any medicine in your system. So most folks that remember hearing some noises or some talking will say afterwards that they remember hearing it, but they just didn't care about it. So it really wasn't a big deal to them. We try to tailor that very specifically to each patient and their needs. The next thing I'd like to talk to you about is our pain management protocol, and that actually starts off before surgery. We believe here it's best to give you medicines before surgery, and that's called preemptive analgesia, as well as a couple of different kinds of medicines, which is called multimodal analgesia. If you've looked at any of that stuff online, you've probably come across those terms. The reason that that works better is we found it's better to have the medicine in your system before surgery, and if we use different kinds of medicine, we don't have to use as much of each one to get the same effect. What that really means is we can give you less of the medicines that are likely to make you sick and likely to make you sleepy. So you're going to just feel better after surgery. We're going to start off with a couple of pills in the holding area that you'll take. A few of them are pain pills and one of them is an anti-nausea pill. You'll come down, we'll do the spinal and give you sedation in the operating room. And then once you get up to the orthopedic floor, you will have a pain button to push if you need it, as well as scheduled oral medicines that work in different ways like we just talked about. We found that patients who undergo this procedure or protocol for the anesthetic have very good pain scores after surgery. During the first 24 hours, typically pain scores are anywhere on a scale of 0 to 10, with 10 being really bad, from 1 to 3 with our protocol. If we don't use the protocol but still do a spinal, sometimes they'll be in the range of 4 to 6, kind of the medium pain range. But if we have to do a general anesthetic for whatever reason, the pain scores are typically somewhere in the 7 to 9 range. So clearly what we've developed works very well and it makes patients very happy afterwards. In addition to the pain medicines, we'll give you some anti-nausea medicines, or antiemetics is what they're the other name for them. You'll get a pill ahead of time, and then you'll get a couple of different IV medicines during your surgery that will be working when you wake up. For the vast majority of folks, that keeps you from getting sick, and they feel good again afterwards with the combination of other pain medicines that we've used. One thing I would like to mention is the specific monitoring you're going to be receiving on the orthopedic floor 4B. It's a special little cannula that sits below your nose and looks kind of funny if you haven't seen it before. But what it does is it actually measures how much you're breathing. It's not measuring the oxygen in your blood, but measuring how much you're breathing. And that's important because that's the first thing that's going to alarm if you stop breathing, which can happen again with the certain kinds of patients I mentioned earlier, specifically the sleep apnea folks. We want to know if you're breathing, and the pain medicines definitely affect that. So if you're getting woken up during the night by a monitor, that's what's happening. You're not breathing, so it's very important to breathe, obviously. So that's why we like to monitor that, and it is cutting-edge technology. It's the latest thing in the anesthesia literature, and we've been doing it here for 3 or 4 years. So you're getting the latest and greatest thing by coming here for your total joint surgery. One nice thing about working here at Memorial is that we can always change what we do if we find something better, and just know that you're getting the best that we have right now, and I think you'll be happy afterwards if you've been through it before with something different. I think you'll be happy with what you get this time. I'm going to answer some common questions that we get on the day of surgery before your anesthesia. The first one involves, is there a difference between the anesthetic for a total knee replacement and a total hip replacement? There is a small difference. We still do like to do the spinal anesthetic, which is the same for both cases. But for the total knee replacement, we also like to add a femoral nerve block, and that helps decrease your requirement for pain medicine after surgery. It's still available if you need it, but what the femoral nerve block does is it numbs up around 75% of your knee joint, so you basically need less pain medicine. The femoral nerve block lasts anywhere from usually around 16 hours to 24 hours, and it's done after the spinal anesthetic, so most of the time you don't even know that we've done it, other than the fact that it'll be working after your surgery's over with. After the femoral block is in and you're up on the orthopedic floor, it's very important to use the nursing staff or therapy staff to help get you out of bed or out of your chair. Because even though it may not feel like it, you will have some weakness in your quad muscles on the top of your leg. So you always want to have help from Memorial employees getting out of bed. Another common question or complaint is about the noise levels up on the orthopedic floor. And most of those noise levels come from the monitors that we are using. I mentioned earlier about the capnography that we use to monitor your breathing, and that machine can make a lot of noise if you're not breathing. It can also make a lot of noise if the oxygen level in your blood isn't as high as we think it should be. Those monitors are meant to be annoying because they mean you're not either breathing deep enough or breathing often enough. So we want them to bother you, we want them to wake you up, because obviously, as you can imagine, breathing is a fairly important thing that you need to do, and that's why we're monitoring it. So we're sorry if it bothers you a lot, but they're completely there for your safety and to get you better as fast as possible. Another common question involves the safety of spinal versus general anesthesia. The most common side effect of a spinal anesthetic is a headache, and in the past 10 to 15 years, the incidence of that has decreased dramatically, mainly because we're using much smaller needles now than we used to in the past. Another common concern along those lines is, am I going to be paralyzed after my spinal anesthetic? The chances of that happening are extremely low, and you had a higher risk of having a car accident on the way into the hospital the morning of surgery than you will of being paralyzed from your spinal. Another common question that we have involves, if you've had back surgery before, can you have a spinal anesthetic? Most of the time, back surgery is not an issue for providing spinal anesthesia, but that's a good discussion to have with your anesthesiologist on the day of surgery. Another common reason for not doing a spinal would be certain types of medicines that you're on. And again, those will be reviewed by your anesthesiologist, and you'll go over those things on the morning of surgery. As with any major operation, there are always going to be some risks. We think that by choosing a spinal anesthetic over a general anesthetic, we're decreasing those risks as much as we can. And we know that choosing a spinal over a general certainly doesn't increase your risk of having any anesthesia complications. We think it's the best thing for you. Combined with our pain medicine protocol, we feel that you do the best and have the most speedy recovery this way.
So after you have your surgery, and Dr. Satovia mentioned that multimodal pain management, that's something we're going to use while you're in the hospital. We'll give you one pain medication, and depending on the type of pain you're having, and if that one isn't effective, we have more types of pain medication that we have available for you, and we'll get that pain under control to help keep it managed. Now that pamphlet that's in your binder called "What Can I Expect After Surgery" is all about pain management. That'll help you know what you need to do to help prepare for how to control your pain while you're in the hospital. So your responsibility and us managing that pain together is to use that pain scale. So 0 on the pain scale means I'm not having any pain, none whatsoever. And 10 on that pain scale means this is the worst pain I've ever had. You'll be somewhere in between those two extremes. So you tell us based on your pain level. If it's a 7, 8, 9, or 10, it's a strong pain. So we know what kind of pain medication you need to get that kind of pain back under control. If you're in the 4, 5, 6, maybe into the 7, then that means there's another type of medication that's longer acting, and we can give you that kind of medication to help get that pain under control and to keep it under control for a longer period of time. Now, if you're down in that 0 to 3 range, you might need a little bit of medication, something mild, or maybe you don't want anything at all. It just depends on you and your nurse. And there will be someone coming in just about every hour to ask you, how is your pain level? What is the number at? What number are you at right now? And so we'll ask you frequently, please let us know if there's anything we can do to help with your pain management. Our responsibility, again, checking you frequently and getting you the best kind of pain management available to you. Safety in the hospital. This is important. For at least 24 hours, you're going to have on red socks. Those red socks will go on before you go into the surgery room. They're going to be on when you come out of the surgery room, and they're going to stay on for about 24 hours. And that's because red needs to be a stop in your mind so that you know not to get up without staff assistance. Our staff members have been trained on how to use a gait belt properly, which is a strap that will go around your waist that they can use to help upright you if your leg starts to give out. And you wouldn't know if your leg was starting to give out, you just would have it give out on you before you even knew it was happening. So our staff members are also trained on how to block your leg with their own knees so that that leg doesn't give out. Also, they know how to help use your walker to help upright yourself in that event. So please use us for assistance while those red socks are on. Now, after therapy and nursing get together, they're going to discuss how well you're doing, how safely you're moving around. Once they feel you're safe to get up and move around on your own, they're going to change those socks to a different color. Say maybe gray, blue, brown possibility. It's all dependent on what size you wear. All of our socks have a non-skid surface on the bottom, so you won't have to worry about sliding on the floor while you're in the hospital. And that's something to think about even at home. You want non-skid so that you don't slide on a slick floor. So after the red socks come off, then you can get up, go to the bathroom on your own. I encourage you to take a walk around in the room or even out in the hallway if you so choose. That will help to start your recovery process. Please don't ask your family to help you up while you have the red socks on. If something happened, they would feel horrible, and so would you. We don't want that to happen. Let us help you. That's what we're here for. But just to let you know, items before we show you those metal components, the plastic components, and some bone structure and how they fit on are just a little few things. These things up here on the board. So the metal components, they're made up of different mixtures of metal. Cobalt, titanium, and chrome, that's the most common metal mixtures. But there are other metal mixtures that your surgeon has available to him or her. And so they will pick out not only the right type of metal mixture, but also the right size of that metal component. It's not a one size fits all. There's different sizes for different bone structure. And when they do the surgery, they will literally realign that joint. They will put that joint back in alignment straight up and down, and also they will add the height back that's lacking in your joint at this time. You have a lack of cartilage and some bone destruction going on because of that osteoarthritis. So the surgeons will put that height back in that you're lacking. Also, length of surgery. Surgeons would like me to relay to you to have your family and friends present in the waiting room about an hour after your surgery has started, because they'll want to talk to your family and friends to let them know how you're doing. They may come out into the waiting area, or they may call out, but they want to talk to you and let you know how your family member is doing. Also, longevity of a new joints, and this is exciting, 95% of new joints are lasting 15 to 20 years, and that's a long time. And you can do some things to help prolong your new joint. Prolonging your new joint means 30 minutes a day of either walking, swimming, or bicycling. And that can be 30 minutes all at the same time if you prefer, or you can break it up into 10 minutes 3 times a day. Put it into your schedule, however it fits best. Here's what happens. If you keep the muscles strong around that new joint, then the muscles stay strong and they absorb the shock and the pounding and the pressure of every step you take after that surgery. If those muscles are too relaxed and weak, they're not able to absorb that shock and pounding and pressure. So guess what does? The brand new joint takes the brunt of each step. So do yourself a favor, prolong that joint for as long as you possibly can, and that will help by doing that 30 minutes a day, every day from the time you graduate from therapy for the rest of your life. Use of a walker, most people will use a walker for about 1 to 6 weeks after surgery. Now, some people will use a cane, some people might use crutches, but the majority of people will use a walker. We like the type of walkers after this type of surgery, hip or knee replacement, to have front wheels or no wheels. The 4-wheel walker tends to get away from you way too fast after the surgery. So if you have a walker, please bring that to the hospital with you and leave it in the car. Have a family member pick it up. When you're out of surgery, have them bring it to your room. Let therapy adjust that so that you know it's the right type for you and also the right length for you at this time. And if you don't have a walker, please don't go out and buy one, because Medicare and insurance companies will typically cover the cost of that walker after you have the surgery. Your discharge planning staff member will help to set that up and decide from your insurance company who your preferred providers are, and you'll be asked to choose from that list. So we'll get you that walker, and you'll have that to take home with you for the first few weeks. Walker use, 1 to 6 weeks, depends on you and your therapist, and your therapist will graduate you to the next level. And hopefully that will be walking with nothing at all. And then infection control is another item that we want to cover with you. Infections are mostly preventable, and we want to help to prevent that for you. So what we do here at the hospital is we use a MRSA nasal swab to test and see if you've been exposed to MRSA or methicillin-resistant Staph aureus. And then we also have you do a HIPAA showering, and that starts the day before surgery, and then a shower the morning of surgery. So I'm going to cover those 2 aspects. The MRSA nasal swab, you'll have a Q-tip that is swabbed inside of both nostrils, and then we'll test that to see if it's a positive result or a negative result. If it's a positive result, that means somewhere along the way you've been exposed to that MRSA bacteria. And so we can help to protect you if that's the case. So methicillin-resistant Staph aureus means resistant to most antibiotics, but there's an antibiotic ointment that will start in your nostrils starting the day before surgery, and that continues for a total of 5 days. Also, you would get a special IV antibiotic called vancomycin or daptomycin. That is in addition to the normal antibiotics that you would get on the day of surgery. All of those antibiotics go through your IV tubing, so you won't know that they're even going in. Also, you will notice that you will be in what we call isolation precautions. Now, isolation precautions is not to isolate you, the person, it's to isolate that particular type of bacteria. So you can still come out of your room and do everything that you normally would do while you're in the hospital setting. But you'll notice that people who are taking care of you coming into your room will dress in a disposable gown and gloves. They'll help to provide the care that you need to have at that time. And before they leave your room, they're going to toss that disposable gown and gloves in the garbage can and then wash their hands really well before they go on to take care of the next person. Now, it used to be that your family and friends who came to visit you would need to wear that same disposable gown and gloves, but no longer do they have to do that. They can come in and visit with you and not have to put on that disposable gown and glove. If you test positive for that MRSA nasal result, we will give you a call and we will talk about this in more detail. So if you don't hear from us, then you're not positive and you don't have to worry about any of those things. Now, the other type of protocol that we follow is the HIPAA showering protocol, and I'm going to run through that with you. You should have a sheet that describes exactly how to do that showering protocol step by step by step. But the day before surgery, you want to get out of your bed, put clean sheets on your bed, and nobody gets back into the bed until that first HIPAA shower the night of your surgery. So the night of your surgery, when you're ready for bed, you get into the shower, you take your normal regular shower using all of your normal supplies. Wash your hair the night before your surgery. And then you rinse all of that off and turn the shower head off, and then you're going to take that first HIPAA packet, pour a little bit in your hand at a time, rub your hands together or in a washcloth, and spread this everywhere from the neck down. You don't want to put this on your face or in your hair. Get some help if you need some help putting that on your back. After you've applied this everywhere, pay special attention, which just means a little extra hand scrub, to your hands, your feet, the groin area, your belly button, and your surgery leg. After that, wait 2 minutes with that HIPAA on your skin. It's an antibacterial, it's not a soap. So there's not going to be a lather, and also it's going to help lower the number of bacteria on your skin. And that effect will last for several days, meaning the time frame that you're in the hospital and even a couple of days when you get home. So after you waited the 2 minutes, you turn the water back on at the shower head, rinse all of that HIPAA off, and you get out of the shower and dry off with a clean towel. Put clean pajamas on, and then get into your clean bed. The next morning, it's the morning of your surgery. When you wake up, you get into the shower and get your body wet with water. Don't wash your hair the morning of surgery. Get your body wet with water and turn the shower head off, and then take that second HIPAA packet and do that same routine again. A little bit in your hand at a time, smooth that everywhere all over your body from the neck down, and pay special attention to your hands, feet, groin area, your belly button, and your surgery leg. Wait the 2 minutes, and then rinse all of that off. Turn the water back on at the shower head and rinse that off. Now you're going to get out of the shower, get a new clean dry towel to dry off with, and then put clean clothes on, and you're ready to come into the hospital. Now they make it tougher on ladies. There's no shaving your legs for 48 hours after surgery or before your surgery. And also they'd make it tougher for everyone because there's no lotion, powder, deodorant, perfume, cologne, nothing on your skin from the time you've had that first HIPAA shower the night before surgery until after your surgery day. Now, if you have a bed partner or a pet, your pet, try to keep the barrier of your sheets between you and your pet if you can't keep your pet outside of your bedroom. Try to keep your pet outside of the bedroom, but if you can't, that's okay. Keep the barrier of your sheets between you and your pet. And also, if you have a bed partner, they need to get into the shower the night before surgery before they get into your bed, and they need to take a normal, regular shower. They're not having surgery, so they don't need to use that HIPAA. So they take a normal, regular shower, and then they get out of the shower and put clean pajamas on, and they get into the clean bed. And then you draw a line on that bed and say, don't cross this line tonight. So now I'd like to introduce you to Maggie Rice. She is a RN, also a JointWorks educator, and a surgery nurse at our Taylorville Memorial Hospital. And Maggie's going to explain to you how those plastic and metal components fit onto your actual bone structure within your hip and within your knee. And she's going to explain how those things happen and what the surgeon is going to do during your procedure.
For this portion, I'll be discussing both the anatomy and the surgery consisting of the total hip replacement and the total knee replacement. I'll get started by introducing the hip. Now the hip is comprised of basically two major joints, and that's your pelvis and also your femur, which is your thigh bone. And with your hip bone, this joint is the largest weight-bearing joint of your body. It's basically the ball and socket joint. And the reason I say that is because most people, when they think about the hip joint, they think about this section of your body. And if you form your hand in the shape of a C and you put it like right below your waist, you'll notice that that's where you feel a bony prominence. And basically, that's not the section that we're talking about, and most people kind of think about that. It's more towards your groin area, and that is the acetabular socket or your hip socket. And that's basically, if you look at this model portion, this part right here is the ball part of your femur. This is your thigh bone. And right here, this is called the femoral head, or the femoral neck. This is your femoral head. And this part also is covered with cartilage, which is a shiny substance. You don't see it on this model because it's This is just the model itself. This fits snugly into the acetabular socket or your hip socket. And basically, as for several reasons, whether it be hereditary injury or weight issues, you tend to have that cartilage wearing down, and when that happens, bone gets exposed. And you may have heard your surgeon discussing things like osteoarthritis, and that's what that is, that wearing down of that connective or that cartilage tissue, exposing bone. You'll feel pain, and so your surgeon may recommend surgery. Now, sometimes when you're walking around, you may feel that you may have some stiffness or decreased mobility. And what our body tends to do sometimes is replace that bone loss by making or producing more bone. And in that instance, you start developing what are called osteophytes or bone spurs. And that may make it more difficult to move, and you create some stiffness, and you may start moving, and because of that bone-on-bone grinding that is going on, that smoothness that used to be on that round portion of your thigh bone is now become flattened. So what your surgeon is going to do, he's going to remove this portion of your femur, the femoral head, after making an incision over your hip bone. He'll expose this portion and remove this portion and take it away. What he'll do is he'll clean out the damaged cartilage that you have had inside of your hip socket, along with any damaged bone that you have had exposed. So once that's done, he'll introduce this metal component. This is your new hip socket component that he'll introduce into your hip socket itself. And if you notice on the outside of the new component, it's pretty rough. And the purpose for that is for new bone to adhere, the new bone growth to adhere to that rough portion. He'll place that inside of your hip socket like this, and it all comes in different sizes to fit your size particularly. So this one doesn't fit this one specifically, but it's just for purposes of presentation. Now, it doesn't come with the cartilage itself. This one has already been imposed inside of it. And if you notice on the back of it, it has holes. Your surgeon will place this component inside of the hip socket using special screws and bone or bone cement. Once he's done doing that, he'll place this, what used to be your cartilage, he'll introduce this polyethylene component inside of the metal component using special instruments. And now that he's finished with your new hip socket, if you remember, we talked about him having removed the old femoral head that had been damaged. You can just pretend and imagine that this is missing. And what he'll do is he'll create a new canal inside of your thigh bone, going down about a third of the way down your thigh. He'll make that canal and use special bone cement. Afterwards, this is your new femoral component, and if you notice, it also has rough edges around the outside of it, and that's also to promote bone adherence with your new bone. He'll insert this a third of the way down, having the new neck, which is the stem. It's a lot thinner than your actual bone, and that's okay because metal is stronger than bone. Once he inserts that using special tools, he'll lastly put the ball component right on top. Now, once he's realigned both your femur with your hip socket, he'll extend and flex your hip back again, making sure that the range of motion is adequate according to specifications. And so if you can imagine, everything is back intact the way it's supposed to be, and he'll be moving it, gliding it back like this, like you had it before, except now you've got the metal components intact along with your polyethylene plastic in there. Now, after that is done, your surgeon will close the incisions using sutures on the outside with staples. And sometimes in some situations, your doctor may choose to put a small catheter right at the incisional site, and that usually is for wicking away any extra fluid. That remains probably around 24 hours, and your surgeon will remove that usually the next day. the staples remain intact for about 2 weeks, and your surgeon will remove that, usually at the office after, like I said, about 2 weeks. It's really important that you handle those very carefully by washing your hands and making sure that you don't get the dressings wet. That's really, really important. So just follow the instructions as your nurse will go over with you, and that's pretty much it for the total hip replacement. All right, now we're going to talk about the knee. And if you will, humor me a little bit because this model doesn't have the actual kneecap. This is the femur, which is your thigh bone. This is your tibia, which is your shin bone. And what you would actually see here would be your patella, which is your kneecap. And these things are held by muscles, by tendons, and ligaments on the side. And in between your femur and your tibia is actually the cartilage, which comes in two semi-lunar shapes, which is called the meniscus. And the meniscus purpose is it's kind of like a shock absorber, like you have in your car, to absorb the shock of impact of your body as well. And at the end of your bones on both the tibia and your femur are shiny cartilage as well that helps with the gliding motion in between with the meniscus here to help so that you're not having that bone on bone that we talked about earlier. So if you think about when you see the bottom of a drumstick, like at the supermarket on a chicken, that's that shiny cartilage that you're seeing. So also as with the hip, because of weight issues or injury or just because of age, osteoarthritis sets in, and you wind up having that cartilage that used to be there wearing down. And when that happens, you have the grinding going on and you have that wearing down that creates that pain and the damage. And when that happens, you decrease motility, you have that bone spurs occurring, and those bone spurs are pretty painful, and they have that shooting pain that goes even up, radiating up your leg and even behind your thigh. So, and that's, again, our body's way of trying to add that extra bone deposit that we really would rather have naturally, but that bone spur just winds up depositing all around the edges, and it kind of pokes at us. So once your surgeon gets you to the operating room, he'll make an incision over your knee, and he'll expose your femur, which is your thigh bone, and also your tibia. He'll begin by moving the patella, which is your kneecap, over just over a little bit to the side. He'll begin by removing the damaged portions of both your femur, your thigh bone, and your tibia, and also the back of the kneecap if needed. He resurfaces all of these areas, beginning with your thigh bone, and he reshapes it. Now you have to keep in mind that this area, this model's kind of worn down, so your knee is not, or your thigh bone is not going to look like this. Once he reshapes it to the model of your new metal component, he'll make a small hollow opening to accommodate the stem of, or the prongs of your metal component, which looks like this. Now these also come in different sizes, and they fit according to the new shape of your resurfaced femur. He'll fill it with bone cement, and he'll insert your new metal component, obviously in a much more sophisticated manner than this. So it'll look similar to this. And once he's done, he has resurfaced and finished the tibia as well. He'll make a hollow opening inside of the tibia, and he'll apply special bone cement as well. And if you notice, there is a stem on the tibia, or the tibial component, along with like a little shelf on the top of it. He'll insert it inside with his tools. And this one, obviously, I don't want to press it too hard, otherwise I'll break the model. But it sits nice and snug inside of your bone. Once he's done pressing that in, he'll replace what used to be the cartilage with your polyethylene plastic. And he'll use a special instrument to press that right inside the shelf of that tibial component. Now, once he's done with this, and as I told you before, I don't have the actual patella or your kneecap, but after he's resurfaced the rear of the back of the patella, he'll apply special bone cement to the back of it, and the actual component has 3 prongs. It's pressed into the cement, and he'll take that patella, the new patella, and he'll move it over to your new joint. Your new joint will look like this. And it's actually like this. Here is your new femoral component. This is your femur, which is your thigh bone. Here's your patella. And here's the back of it, the polyethylene plastic. And here is your new tibial component, your shin bone, with the new, what used to be your meniscus. This is the polyethylene plastic that replaces your meniscus. So he'll extend and flex your new joint to make sure that the range of motion is adequate. He'll close your incisions using sutures and the outside with staples. And just like with your hip, it's really important that you don't get that incision wet, that you touch those incisions after you've washed your hands, and you follow your instructions accordingly. And you'll also wind up seeing your surgeon after about 2 weeks, and you may or may not have that small catheter coming out of your incision that wicks away any excess fluid from the incision. That also may come out probably about 24 hours. So that concludes this portion of the total hip and the total knee replacement. Hi, my name is Maggie Rice. I'm one of the JointWorks educator for Taylor Memorial, and I also work in the surgery department. On the day of surgery, you will be greeted by one of the nurses who will conduct a brief physical assessment on you and also perform a general assessment as well. At that time, after she conducts her brief interview, you'll be asked to change into a patient gown and also asked to sign a permit, which consists of a consent that does delineate the operation that you're having done that morning. At that time, you will be taken on over to the pre-op holding area, where you will be met by quite a bit of people, including your circulating nurse, who will introduce herself or himself and ask you several questions, including your name, the allergies that you have, if any. She will also be asking you what procedure you're having done. And this is something that you will be asked over and over by a number of people, and it's only to ensure your safety, to make sure that everybody's on the same page. Also, you will be met by your anesthesia provider, and he or she will also be going over the different types of anesthesia that he will be offering you, as well as explaining what the femoral nerve block consists of. At this point, your circulator nurse will also take the opportunity to explain how he or she will be removing the hair, and now we no longer use the razors, they use clippers to take away the hair from the operative site, whether it be your knee or your hip. And the reason for that is because we found out that by using the razors, it used to introduce an avenue by which to introduce bacteria, so the clippers are a much safer avenue by which to remove the hair. After that is done, you'll be taken over to the operating room, and you'll notice that on the slide it says it's very cold and noisy, and that is true. It's very noisy because of the air filtration that constantly is cleaning the air in the operating room, but we can give you headsets that can actually play the kind of music that you like. And so please take advantage of that. Secondly, it is very cold. Germs do not like to grow in cold environments, so we need to keep it cold at a certain temperature. Usually, as Jackie mentioned, the surgery takes about 1 to 2 hours. So after the operating room, we will take you on over to recovery room. And we want to make sure that your vital signs are stable, and also to make sure that you wake up from the anesthesia within a certain amount of time. So we want to keep you for at least 1 to 3 hours. And between each phase, your family will be notified of your progress. You may notice that when you wake up in the recovery room, you may have certain things already on the gurney. For example, this wedge that's on the left square is to prevent, if you've had hip surgery, from your legs crossing over. We don't want your hip, your new hip replacement, to pop out. So this is attached with Velcro around your ankles and around your knees, and that's, like I said, just a reminder. You may also see this CPM, your leg, if you have had total knee replacement. We're trying to get away from that. That's just to continuously keep that in motion. On the bottom here on the left hand, you may have already seen that. Some of you may be wearing that ahead of time. Those are called TED stockings, and that's just to prevent blood clots from forming. And on the left-hand side, you will be seeing this. They're air compression stockings. Sometimes they're called pneumatic stockings. And those are put on as soon as you are in the recovery room, and also when you are at rest up in the post-surgical floors. And what these do is they compress and decompress, and that just encourages further circulation and also prevents blood clots from forming. As far as gel pack therapy, you will be given 4 gel packs, and the reason for that, it decreases the swelling and it also helps with the pain. If you're having total hip replacement, if you notice on this little block right here, you have a big Velcro sleeve that includes 2 gel packs, and how it has 2 different straps that strap around, one around the waist, one around the hip, and the 2 sleeves accommodate those 2 gels. You replace those once every 4 hours or so. And the same thing with the knee, except that the knee does not have the straps. It has Velcro already attached to the sleeve itself. So you replace those 2 gel packs as well. And on the unit, they actually have those in the freezers, and you interchange those every 4 hours. While you're in the hospital, you wear those constantly while you're staying at the hospital to reduce that swelling. When you go home, though, you have to remember to only leave it on you for about 20 minutes on, and the rest of the hour, so 40 minutes off. And the important thing is you don't want to be falling asleep at night with it on. So as long as you have the swelling, you want to be able to interchange that, to put them on 20 minutes, take them off for the remainder of the hour. And just a reminder that while in the hospital, even though it says almost on all the time, you don't need to have it on you when you're doing physical therapy. It kind of gets in the way. Just an added bit of information. And also, at the end, make sure that you have all 4 gel packs with you before you go home. They're not replaceable, so it's important that you do take those home. After you leave the recovery room, you'll go up to your respective post-surgical units, where you'll meet your nurse. She'll introduce herself or himself to you, and towards the foot of the bed, you have a dry erase board where they'll write their name as well as the CNAs or the certified nurse assistants. And also, they tend to write down when you took your last pain medication so that you know and you can gauge more or less when the next one is due. They'll also introduce your post-surgical exercises as well and help you with those and remind you to do your ankle pumps, and they'll teach you how to do that as well as physical therapy. They'll remind you to do those important deep breathing exercises, as well as encourage you to drink water to promote circulation. They'll get you up in the recliner that very evening, and that's really important to get you stimulated and get you back to recovery. And remember, you're coming in as a well patient, so you gotta have that really positive mentality. You're a well patient and coming in for surgery. And physical therapy will help you to promote that, as well as the nurses. So keep that in mind when you come in the day of surgery. You're a well patient, getting better. So with that, I'm gonna turn you on over to Todd Morning, who is manager of physical therapy, physical therapist himself. Thank you.
Hi, my name is Todd Morning. I'm the manager of rehab services at Abraham Lincoln Memorial Hospital. I'm also a physical therapist, and I'm one of the JointWorks educators up in Lincoln. So after you get back from surgery, we're going to ask you to do several things hourly after your surgery, and this does a couple things. What we're going to ask you to do is ankle pumps, drink lots of water, and breathing exercises. These are all meant to help decrease your risk of getting a blood clot. Now, we already know you're going to be on a blood thinner, but this is just an added bonus to help decrease the risk of a blood clot. For ankle pumps, what you want to do, you'll be laying in bed or sitting in the chair, is pumping your ankle up and down, or moving your ankle in a circle both ways. That just gets that muscle action going, helps promote that blood flow back to the heart. We want you to drink lots of water, and that does a couple things. Number one, it helps to keep the fluid built up in your blood, so you have a better chance of keeping your blood pressure up. It also helps to increase your circulation, which will help to decrease your risk of blood clots. And then you want to do breathing exercises. when you're stagnant in bed, laying after a surgery or an illness, you have a chance of getting pneumonia, and what we want to do is make sure you're moving the air through your lungs so you're decreasing your chance of that. So what we want you to do is take several deep breaths, and then with your next breath, breathe in through your nose, hold it for 2 seconds, and then forcefully cough 2 or 3 times. And you may even have to do a double cough to really get those lungs to clear. So after surgery, it is very busy. Hospitals are not quiet places. Hospitals are not slow places. They are very busy. You will have doctors, nurses, anesthesia, family members, clergy, a variety of different therapy coming in after your surgery. So we'll tell you what typically is going to happen. In terms of bathing, you will not be able to shower for a couple weeks after surgery. Typically, they want you to wait until your staples come out until you shower. But that doesn't mean you can't take a sponge bath. So what happens in the hospital is, it used to be everybody got a bath at 5 o'clock in the morning. We change the sheets every day, and they thought that helped to prevent infection, but it really doesn't. So what we want you to do is, when you are ready to have your bath, or if your sheets are soiled, or if you just want new sheets, tell us and we will take care of it at that point. Clothing-wise, knee patients, if you've had a total knee replacement, you have to bring shorts. We have got to see that knee so we can check your incision, check your bandage, check for any drainage. It also helps the therapist when we go to exercise you to be able to see what that knee is doing. You also need to bring t-shirt, sweatshirt, whatever you would like on your upper body to make you comfortable. Hip patients can use sweatpants, or they can use shorts. Just make sure anything you have isn't very tight around the waist, because that can be uncomfortable. And again, for upper bodies, for hip patients, t-shirt or sweatshirt is fine. 3 sets of clothing is what we want, because we will not have a chance to launder clothing. You bring 3 sets of clean clothes. By the time you're on the 3rd one, you'll be wearing those home. So it's okay to ask. We know you're going to have a lot of questions. We hope that this presentation helps you to answer some of those questions. But when you get here, you're going to have questions. So what I want you to know is that any question that you have regarding your medication, your procedure, your therapy, your follow-up, anything, it is okay to ask. If it's too hot or too cold, ask us and we will take care of it for you. Nothing is off limits at this point. And it's also a good idea to have a coach or an advocate with you several times throughout the day, so they can see what you're doing during therapy, so they can ask the same questions and hear the same answers that you're getting. It's very important for them to be aware of what you're doing, because when they go home with you, they may be the ones that are walking you. So they need to learn that while you are in the hospital. So what happens therapy day 1? You've had surgery on Monday. Now we're on Tuesday morning. Tuesday morning, typically therapy is going to start 8:30 or 9 o'clock in the morning, depending on the schedules. Before therapy comes in, we want to make sure that you are being aggressive with talking to the nurses to make sure you've had breakfast, if you're able to eat at that point, that you've been to the bathroom, that if you're going to be dressed, that you've got some comfortable clothing on, you've had your pain medicines, and so you are ready to go when we hit the door. Like Maggie said earlier, you are not sick. You are here to get better. We want you mimicking what you're going to be doing at home. So the more you can act like you're at home and getting these things out of the way with the help of the nursing staff, the sooner that you're going to get out of here and the better you're going to do with the program. So, therapists are going to come in, physical therapy and occupational therapy. Physical therapy is going to help you to get up and walk. We're going to move your knees. We're going to teach you some exercises, and you will find those exercises in the back part of your book. I believe it's under the exercise tab. Occupational therapy is going to work with bathing and dressing issues, any cooking issues that you may have. What we're trying to do is prepare you to get back home within a couple days. You're also going to get up and walk. Most people say, well, I can't walk, I just had surgery. No, day 1, you are up walking. We'll start out in your room. As we move forwards, we'll start taking longer and longer walks. Most of your day will be spent in the chair, unless you're in bed for the CPM. Sometimes you just need to take a little nap, and that's okay, but you'll be in a nice, comfortable recliner. Most of your day will be in that. And I would say, once the therapy starts, we encourage visitors in the hospital because it's good to socialize, it helps you feel better, but we want to make sure your visitors are not interfering with the therapy. So if you can recommend to your visitors that if they could come later in the afternoon when therapy is done, that will help us a lot so we can get all of our therapies, all of our nursing care out of the way, and then you can have that social time later. Now, that does not apply to your coach. We want your coach there during therapy. Day 2, we start walking longer distances. You're up, you're dressed, you're ready to go by 8:30 or 9 o'clock in the morning. We're going to go up and down stairs, either a half flight. Most of our gyms have a half flight of stairs. If you need to go up and down a bigger flight of stairs, and we know some of you will have to, let us know and we'll work that out so we can practice going up and down a full flight of stairs. We're also going to practice getting in and out of a car. So what we will do is we will simulate that car transfer either using a mat table, or if you're at Memorial, you may be lucky enough to come down and use the half car. In Taylorville and Lincoln, we do not have a half car to practice on. But it's extremely important, especially with a hip replacement, that you learn how to do it properly and safely. And you have to know that from the time you leave the hospital on forever. So tips for swelling and pain control. You want to take your pain pills before the therapy sessions. Why? Because therapists like to typically do things that may cause your knee to be more sore. So we want you to be medicated beforehand. And I would tell you that if you are on a pain schedule and your pain pill is starting to wear off, and you know therapy is coming, you need to be calling that nurse to get that pain medicine before your pain pill wears off completely. If you let that pain get a hold of you and really get you down, it will be a lot harder for that pain pill to take effect. We also have the gel packs that Maggie talked about. You want to use those for as long as you need to decrease the swelling, even after you go home. You want to elevate your leg 2 or 3 times a day, 20 to 30 minutes each to help decrease swelling. You can lay on the bed or the couch with pillows lengthwise under your knee or under your legs. You want to elevate your feet above the level of the heart. Now, what I want to caution you against, you never ever with a knee replacement want to lay on your back or on the couch with a pillow directly under your knee. And the reason for that, if you go to sleep with a pillow under your knee is going to wake up in that position and you're not going to be able to straighten it very easily at all. And it makes for a much harder recovery if you do that. So if you want to put a pillow to elevate your leg, make sure it's throughout the entire leg and not just underneath the knee. Also, a good tip to help with pain and swelling is to get up and move around. The way the body works, the nerves like movement. And when you have all of those toxins there after surgery, that kind of irritates the nerves. And if you can get up and move around and flush those toxins out, you'll be in much better shape in terms of helping to control your pain. So, what happens when you're ready to go home? You have 3 options. You have outpatient physical therapy, you have home health therapy, and extended care facility. Ideally, if you're doing well and you can get out and go physically, then we want you to come to outpatient physical therapy. We have the equipment to help with your pain and swelling. We have the equipment to help you exercise. If you're just not able to get out and go and you need somebody to come to your house to give you therapy, then we can do home health therapy through one of the local agencies. Home health therapy will send a nurse and they'll send a therapist. So the nurse will come and do your blood work and the therapist will come out and exercise you 2-3 times a week. If you need a little bit more time in the hospital, an extended care facility or a swing bed or a skilled unit might be the best choice for you. Usually that's just for a very short time until you're on your feet and you can take care of yourself at home. Your discharge planner at any of the 3 hospitals will talk about these options with you and decide in conjunction with your physician as to what the best course of discharge is. I'd like to introduce you to a video with a real-life patient that went through Memorial JointWorks. His name is Kurt Heller. He had a bilateral knee replacement, so he had both knees done at the same time. Even if you are not having knee, if you're having a hip, the process is the same throughout the doctor's visits, through the surgery, and then after that for the recovery. He was gracious enough to let us follow him with a camera throughout his pre-op, operation, and then post-op to get a true life experience about what you're going to go through.
As far as sitting here goes, I'm not in any pain. If I stand up, I have pain. If I walk, I have pain. I can't stand for very long. I can't walk very far distances because they start to grind and they lock and they're pretty painful. So there is not much quality of life unless I'm sitting down right now. And that's why as an equity, we like to go to Cardinal games. I like to golf. I can't do any of that stuff anymore. We used to go walking together. I can't even do that anymore. I miss being outside, walking, golfing, whatever, you know. I'm really getting tired of putting up with the pain. I'm actually looking forward to it. You know, I'm not really nervous right now. I'm sure I will be Wednesday morning, but I'm excited about getting it done. I'm excited about getting rid of the pain, and I'm looking forward to having some new knees. I was a little bit nervous because I didn't know what to expect, but then, of course, everybody surrounds you with the care and compassion, and then they started hooking me up to the IVs and gave me the medication to relax you. And when she did that, I don't remember anything until after they brought me back to the room. See you there, love you. See you, Pastor. I think I love you too. Later that afternoon, they got me up, had me walking around and stuff, which I thought was kind of neat, you know, because I didn't think I could recover that fast or be able to use the new knees that fast. Bounced back, came home Sunday, and each day I've gotten a little more energy back. So, but 2 weeks into it, I feel really good. It's been 2 weeks yesterday. I feel like a new person actually. I've got more energy. My knees don't hurt when I walk on them. I think I'm getting around pretty well for 2 weeks. I can even walk without my walker when my wife's not looking, so that's good. There wasn't as much pain as I thought there was going to be. I was expecting the worst. I was expecting, like on a scale of 0 to 10, I was expecting a 10. As soon as I woke up, as soon as the anesthetic wore off, I expected each knee to be a 10 because I've heard bad things about surgeries. I never felt that. I never got up to a 10 with the knees themselves. I wouldn't mind hitting a little white golf ball around one of these days. But I'm just looking forward to be able to walk, you know, from here down to the street and back. You know, just that simple things like that, and then I'll worry about the golf later. One of my goals, if you remember the earlier part of the tape, was to go to the Cardinal game, walk from the hotel to the Cardinal game and back, and I did that last weekend. The nurses, the physical therapists, occupational therapists, all those people, you could tell they really enjoyed their job. So they gave you the one-on-one care that, actually more than one-on-one, there were 2 or 3 of them in there all the time, taking care of me, giving me that care that I needed. I'd sing their praises. I was very impressed and very pleased. So in that respect, it went above and beyond my expectations, the treatment I received. It was good, very good. And I'd like to thank my wife because she was my coach, and I could not have done it without her. And boy, if I had to do it again, I'd do them both again in a heartbeat. I'm very, very satisfied.
So just a couple more tips before we close. As a physical therapist who's done home health in the past, I know it's very important to prepare your home now for your discharge. So in the binder, you will find a page that talks about how to prepare your home for discharge. You may have to move furniture. You may have to get a riser for your toilet seat. You may find that a walker, which is typically 19 to 24 inches wide, will not fit through your bathroom door. These are all problems that need to be solved today, leading up to the surgery, rather than waiting till the day you come home and find out that it's not set up properly. So, thank you very much for watching the video with us today. We hope it's been educational for you. If you have any questions, please don't hesitate to call us at the JointWorks program at Memorial. We thank you for choosing Memorial Health System and the JointWorks program at Memorial. And whether you're having surgery in Springfield, Lincoln, or Taylorville, we are sure that you're going to have a great experience. Thank you.